Thank you, Dr. Amita, and good morning, everyone, and a very happy new year to all. And also, I don't know, one of our investigators who's done a lot of analysis and predictive modeling for us would have joined on Zoom. He is Dr. Santam Chakravarti from TMC Kolkata, and he's done some brilliant work. Yeah, I don't know. I cannot make out whether. Yeah.
Good morning, madam. I am available.
So the Department of Radiotherapy will be sharing its experience on shortened duration of radiation in breast cancers, as Dr. Amita just mentioned. We will be presenting our preliminary outcomes of the toxicity of the short adjuvant schedule, radiotherapy schedule in breast cancers as a part of a trial. We all know that radiotherapy in breast cancer actually confers survival benefit, and there is solid evidence to that. Radiotherapy, therefore, is an integral part of the breast cancer management, and we can't do away without it, especially with the conserved breast cases. But as was just mentioned, radiotherapy has its own inherent logistic issues. That is, that the women have to come daily, Monday to Friday, and they have to come for 5 to 6, 7, 8 weeks as is required. And that can be posing a problem. It is cumbersome, and people do not sort of appreciate it. So why do we call them for so long? Why do we give radiation in portions and not like whole radiotherapy given in one day and be done with it? Because we give in portions and we divide these portions. These are separated roughly 24 hours apart. What happens during those 24 hours is that when we are giving radiation, it treats, the aim is to treat the tumor, but there is some surrounding adjoining normal tissue which is there and which we cannot remove from it's inadvertently there. Now, in between those two portions of radiotherapy that we are delivering, the normal cells which are sitting in, which are coming in the beam trajectory, they are normal and they are fully developed. They have the ability to recover back. Whereas the tumor cells, which are malformed, do not recover. So what happens is in subsequent fractions or portions, the tumor eventually, hopefully, wilts away or dies off, but the normal cells tend to bounce back. So that is the differential that we create, and that is to our advantage. The other thing, which is a bit of basics of radiobiology that we actually need to know for the purpose of this presentation, is that all cells, they respond to the radiation in a manner, either like in early reacting tissue, which is all the rapidly proliferating cells behave like an early reacting tissue, and they are dependent on the total dose that we deliver. The slowly proliferating cells in the body, they respond like a late reacting tissue, and they are dependent upon the fraction, the portion size that we administer, the dose per fraction. Tumors have a choice. They can behave like early reacting tissue or late reacting tissue. The rapidly proliferating tumors usually behave like early reacting, and the slowly proliferating ones behave like the late reacting tissue, and so they are dependent upon the portion size. Earlier, it was believed that breast tumor is like an acute reacting tissue, like squamous cell carcinomas. So in adjuvant setting, we would give conventional fractionation of radiotherapy, which was to 50 grays, 25 fractions over 5 weeks to the whole breast or chest wall, whichever the case may be, at 2 gray per fraction. As our understanding of radiobiology improved, we realized that breast tumor and certain other tumors like prostate tumors, they behave like late reacting tissues. So they are actually very sensitive to the changes in fraction size. which means that if we move from 2 gray to 2.5 gray, we can expect a far greater tumor cell kill. And this is a concept of hypofractionation, which means that we give larger size fractions, and therefore, because we are constrained by the dose that we can deliver, we deliver that in smaller number of fractions, and so the treatment becomes smaller. Like I said, anything above of 2 to 2.5 gray per day, if we are delivering in a fraction size of that, in a shorter treatment, that becomes hypofractionation. And then we do certain amount of downward scaling of the total dose to bring the equivalence into account. And all this is possibly possible with the better technology and the techniques that we have as of today. Does hypofractionation benefit? Yes, it does. Fewer fraction means lesser cost, more convenience. Patient has ease of traveling, ease of stay in the place, and that all contributes towards better compliance. And like I said, peculiar radiobiology that they behave so slowly, the breast tissue, breast cancers, and say prostate, that those are the areas where hypofractionation has been found to be beneficial. From the healthcare system's point of view, it is beneficial because our throughput, the machine increases. Inevitably, all these machines are overburdened. If we have shorter fractionation, we benefit because the waiting times for the patients decrease and the number of patients that we can treat become more. Are there concerns? Yes. At no cost can we compromise upon the loco-regional controls. And also, we have to ensure that the toxicity that we are giving to the patient is manageable and comparable. Acute toxicity in case of breast would be largely skin and some others. They would be dependent upon the total dose that we are giving. And the late toxicity in case of breast would be the underlying heart, especially in case of the left-sided breast cancer, and where we need to be cognizant of the fact that dose per fraction would play a role. So that was the evolution in hypofractionation story. And there are people who have worked systematically in a randomized fashion from Canada and from the UK, who have given us these trials, these landmark trials. The rationale is the same, that breast cancer tissue is sensitive to fraction size. Our understanding was now that. And so if we were to increase the fraction size from 2 gray to 2.6 gray, we would decrease the number of fractions from 25 fractions to 15 fractions. If we do that, then the treatment time would come down from 5 weeks to 3 weeks. This was the genesis of one of the landmark trials, that is the UK START-B trial, where the schedule design was 40 grays in 15 fractions over 3 weeks. This was called as the modest hypofractionation. And this compared itself, this arm was compared to the then standard of care arm, that is 50 gray in 25 fractions over 5 weeks at 2 gray per fractions. And the primary endpoint in all these trials has been locoregional relapses that we see, that we get to witness. And they published their 10-year median follow-up results showing absolute equivalence between the two arms. If at all, the 40 gray arm was showing lesser number of relapses, and therefore the 3-week schedule became the standard of care for breast radiotherapy in adjuvant setting. And it was universally accepted because of its comparable relapse rates and adverse effects. So the next logical question was that if we can go up to 3 weeks, can we go up to 1 week or 2 weeks, say? So we were now looking for the limits of hypofractionation that breast cancer tissue allowed us. This was when we were venturing into the zone of ultra hypofractionation or extreme hypofractionation. The rationale was that breast cancer tissue was not sensitive. It was probably very sensitive to fraction size. And so if we were to increase the dose per fraction from 2.6 to say 5.2, decrease the number of fractions from 15 to 5, and decrease the treatment time from 3 weeks to 1 week, maybe we could achieve a similar kind of result. So that was the genesis of another landmark trial, which was the UK fast forward trial, where the structure design, schedule design was 26 gray in 5 fractions over 1 week. And this was compared to the now standard of care, 40 grays in 15 fraction over 3 weeks. They introduced another arm to it that was giving a slightly higher dose over 1 week, that is 27 gray in 5 fractions over 1 week. Why did they do that? Because they were now looking for the exact equivalence. They were looking for the exact point where the limit of hyperfractionation could be achieved. So this was a 3-arm trial with 4,000 patients, and most of these patients were actually screen detected early tumors or low risk tumors, and low risk tumors. So they published their results at 71 months, about 6 years of follow-up. And what they reported was that the acute side effects were no greater, especially in the 26 gray in 5 fraction arm, which behaved quite similar to the 3-week schedule. And the late cardiac toxicity was not much mentioned in this trial, because you need a longer follow-up. Now that our understanding, and we are now very sensitive towards the cardiac toxicity, we realize that it takes much longer to appear. And so that never got discussed in this. Maybe that was the limitation of this early presentation. Now, this trial was published in the Lancet in April 2020. That is when COVID pandemic had started. So based on this evidence, there was an overwhelming acceptance and adoption of 1-week radiotherapy schedule by many oncologists across the world for all the breast cancers, all sort of even advanced breast cancers were included in this, even though the trial was not designed largely for advanced and high-risk situations. So that was regarding literature. Regarding our journey with hypofractionation at SGPGI, it started somewhere in 2011. Although these 3-week schedules were published in the early 2000s, and by 2008, we were still practicing 5-week treatment till 2010. And then we improved upon our techniques, and by October 2011, we had routinely shifted to 3-week schedule, which we later audited as well. The other thing, that the point of concern that I mentioned earlier, was that heart was becoming increasingly important for us, especially in left-sided breast cancers. And so there are several techniques that are available, cardiac sparing radiotherapy techniques that are available in the market. One of the simplest being what is we call as DIBH, deep inspiratory breath hold technique, where we train the woman to take a deep breath and hold it for about 20 to 30 seconds, so that the cardiac, we are at the time of radiation delivery, we are able to decrease the cardiac exposure by lung expansion, and because the heart would be displaced outside the beam trajectory. So that was a good technique, which we will just talk about. I think that was the time when we were ready to ask this research question of 1-week treatment in a garden variety of cases, including the advanced ones, which we did in 2021. These are some of the publications that we did in the hypofractionation. Audit was carried out where we found that our results of 3 weeks were non-inferior to the historic controls, and the toxicity was similar. Similarly, we worked on the DIBH, and we found in our set of patients that we evaluated, we could very effectively decrease the mean heart doses and the dose to LAD significantly if we practice DIBH breath hold technique in left-sided breast cancers, as compared to when we ask the patient to breathe freely while the patient is getting irradiated. Coming to the trial, We are part of this multicentric trial, which was started by TMC Kolkata, and CMC Vellore is a part of it, and we are the last entrants, the third party. And we were to induct 2,100 patients and compare the 3-week schedule that was the standard of care with the 1-week schedule. In non-metastatic, biopsy-proven invasive epithelial cancer of the woman. So largely all comers, or predominantly all the garden variety was included. This was the schema of the trial, where the stratification factors were the surgery type that was done, mastectomy or breast conservation, regional nodal irradiation, whether was given or not, triple negative breast cancer, and the treating institution. We at SGPGI have contributed to 23 patients for this trial, and for the purpose of this presentation, we find that 187 are today evaluable, of which left-sided cancers were 92, and we could practice DIBH in 29 patients because of our machine replacement. Others could not be practiced. As a part of this trial, we had excluded other histologies, metastatic disease, bilateral disease, recurrent disease, and non-compliant patient, male patients, etc. So it was logistically an attractive thing, and we were set out to ask the question whether it was working in advanced and high-risk diseases. And by mid-December this year, 2024, we are now closed for the accrual because 2,100 patients have been accrued. Primary objective results are awaited for, and they are for the future. At the moment, centers are looking at the toxicity profiles and the cost sub-study and the quality of life. I'll change gears a little bit. Toxicity is a major concern, as you can see, and occasionally we do get to see this kind of toxicity at the skin level, where the skin is, there is abrasion that you see. This is a grade 3 toxicity, and this kind of toxicity will always be bothersome and of nuisance. So people have looked into that as well. And all the randomized trials have actually published their acute toxicity sub-study report. Also, all of them consistently are finding what UK Fast Forward has published. That is that with the 1-week schedule, the grade of toxicity remains mild, the pattern remains similar, and it is usually not crossing the what the 3-week schedule toxicity was given to us. The same has been published by TMC Kolkata, and PGI Chandigarh has been following a 2-week schedule, which they published in Lancet in 2024, and their toxicities are also no greater. Coming to the heart, so this is a seminal piece of work done by Sarah Darby and her colleagues, where they looked into the risk of ischemic heart disease in women after radiotherapy for breast cancer. It was a population-based case control study of 2,100 patients. What they surmised was that each gray increase of mean heart dose increases the risk of ischemic heart disease by 7.4%. So the bottom line remains that no dose to the heart is safe, and that is very relevant in cases of left-sided breast cancer. Now, are we the only culprits? The answer is clearly no. There is ethnicity, there are the age of the patient, lifestyle, the comorbidities, and the cancer treatment that is given to them, other cancer treatments all contribute. But radiation, of course, does, and the cardiac late effects because of radiation take years to manifest. Maybe they usually appear in second or third decade. And so that needs to be looked into. So there is a lifetime risk that we are giving to the patient, excess of what the patient already has. People have worked on predictive modeling, trying to see, this is a German study where they've seen mathematically that there is a baseline risk, say about 1 to 2% in European women. If you give radiation, the risk would increase to at least 5% if there are no other factors available. But if you treat them by cardiac sparing, then you probably decrease the risk predictably to low levels. So at this point in time, with the trial that we were running, we could do two things in case of heart. One was to look at how much of dose we were giving, the dosimetry. And secondly, was that dose increasing the risk, and how much? So that is what was done, and we will be talking about it. So since we know that this problem is real, and although it is distant, especially with the fraction size that we are giving, this is just to show you that at some point 20 to 25 years later, the breast cancer survival benefit that we are offering to the patients probably peters off, but the effect on the heart stays. And that's why we should be careful that cancer survivors of today should not become heart failure patients of tomorrow. That should be always in our mind. So in the next 25 minutes or so, we will be talking about the basics of radiotherapy planning that will be dealt by Mr. Senthil Kumar, who's a senior medical physicist in our department and takes care of all the plannings. The demography, the acute and cardiac toxicity doses of SGPGI would be dealt with by Dr. Dakshita Singh and Dr. Irish Parashar, who are residents in the department, and both are doing their thesis in breast cancer. Dr. Shagun will compare our results with the literature, and we would want to have a cardiologist's perspective from Dr. Aditya Kapoor, because after all, the patients, our patients of today may become his patients, his future patients, if we are not careful today. And the downstream effect of a trial of this nature would be discussed by Dr. Shalin Kumar. So thank you, and Mr. Senthil.
Good. Good morning to all. Today I'm going to the discussion part for breast radiotherapy planning. So the basic of radiotherapy planning, which we just put the fields like this is the yellow beams that is comes from both end because of the breast curvature. These are called tangential beams. So you can see here the heart and lung part of heart and lungs are coming in the beam trajectory. So this we can avoid by using the different using contemporary blocks or shaping of the beam by MLC. So you can see then in this case, that is, see here, this is the block and this is the MLC part. So we could easily shape of the target. And in case of pendulous breast or some patient with a bulky breast, so we ask the patient to lie down in supine position so that the heart is away, the breast is away from the heart. So you can see here, this is the picture showing depicting that the same thing, that the breast is away from the heart. So now coming to here, the deep inspiratory breath hold technique, it is this, something that we practice routinely in our department. Also, it is practiced in worldwide to spare the heart. So in this case, the patient is first trained and take the patient in supine positions. After that, while the patient's breathing, the lung is expanding, then the heart is pushing downwards, so that the heart is away from the beam trajectory. So the technique is improvised with the coaching. That means a video coach device also it is placed. It is convenient to the patients to regulate the breath during the treatment. So now you come in this session, that's in this section. So the axial part are showing that free breathing case, that the heart and some LEDs are coming in the beam trajectories. So the main heart dose also we seen in the case, the 4.03 gray. But when compared with the DI-based technique, so the heart and the part of lung also, the lung is coming, but the heart is totally is avoided. And we saw the heart mean dose is only 1.8 gray. So for this trial, we also underwent a pre-trial and on-trial QA of a facility questionnaire and process document collating details of techniques were duly filled and submitted. Subsequently, we have done the dosimetry data of 20 patients treated with the standard fractionation in over 3 weeks. Also submitted. So once the results satisfactory, then the physics team of TMC Kolkata, they visited the site and they carried out the QA part on the machine side uh, for dosimetric purposes. Thank you, Dr. Dakshita, please.
Good morning. Good morning, everyone. Today I will be discussing about the patient demography and the acute toxicity data. Out of nearly 1,000 women with breast cancer registered in the department from the year 2020 to 24, we have recruited about 227 patients in the trial, and out of these we have evaluated the data of acute toxicity and cardiac dosimetry in 187 patients. These patients were randomized into two arms. Arm A with a 3-week standard treatment of 40 gray 15 fractions over 3 weeks consisted of 96 patients. Arm B with 91 patients with 26 gray 5 fractions over 1 week. That was randomized to Arm B. The toxicity assessment was made using common terminology criteria for adverse events, and it was the acute toxicity we documented till 3 months after radiation. Looking at the patient demography, our trial included patients ranging from age 22 to 81, and the most common age group that was seen was 41 to 50 years of age. Looking at the cardiac risk factors, diabetes mellitus was seen in about 14 and 19% of the patients in both arms respectively. Hypertension was seen in 15 and 16% of the patients. History of cardiovascular disease and smoking was seen in one patient or 1% of the patient respectively. And T stage, talking about the disease stage status, we included a garden variety of patients from stage T1 to T4. The T3 to T4 patients were about 39 or 40% in both the arms, and we included about 17% of the patients, 71% of the patients in our trial, they were node positive. The left-sided breast cancer cases and the right-sided breast cancer cases, as well as the BCS and MRM cases, they were almost equally distributed among the two arms of the trial. The biologically aggressive type, that is the triple negative breast cancer cases, they were about 41% in arm A and 43% in arm B. The most common histopathological grade that was seen was grade 2. There were about 2/3 of the patients who had received anthracycline as a part of their NACT or the new adjuvant chemotherapy before radiation. We have also calculated the trastuzumab and tamoxifen exposure in the patients. In case patients of breast cancer BCS, we usually give an extra bolus boost dose to the patient at the intracavitary site. And the bolus is usually given in the MRM patient, which is actually a tissue equivalent substance that we use over the chest wall. These usually have an implication on the acute toxicity or the skin toxicity. The supraclavicular fossa dose is usually given to high nodal burden diseases and also to high-risk cases. These were about 77% of the patients in both the arms. Now let us discuss about the grades of toxicity. The CTCA version, it grades toxicity from faint erythema to severe consequences like skin necrosis and ulceration. Here are a few examples of the toxicity that can be seen after radiation. Here we can see grade 1 toxicity with mild hyperpigmentation and faint erythema. In the next example, there is a dry desquamation and hyperpigmentation again that can be seen. In the third patient, there is a visible moist desquamation and hyperpigmentation, which is a bit notorious for the patient for the toxicity. Looking at the overall toxicity in the 3-week schedule versus the 1-week schedule, the most common toxicity that was seen across both the arms was skin hyperpigmentation and dermatitis. That was also grade 1, followed by grade 1 chest wall pain. The most common toxicities across both the arms were usually grade 1 and grade 2. They were manageable. And grade 3 toxicity was seen across only 3 parameters: dermatitis, dysphagia, and chest wall pain, and that too seen in only the 3-week arm. Fortunately, we haven't noticed any grade 4 side effects in our patients. Also, the side effects like neuropathies and the lymphedema component, these are a bit lower because these are acute toxicity details, and these side effects tend to be seen more on as a chronic side effect. Moreover, our patients usually witness hyperpigmentation instead of erythema, because in Western population, it is very frequent to note erythema, but our patients really manifest erythema because of the skin color. Now I invite Dr. Iresh with the cardiac dosimetry data. Thank you.
Thank you, Akshita. A very happy morning to the esteemed faculty, seniors, and my dear friends. I'll walk you all through the cardiac dosimetry data. Now, this first table over here shows the upper limit of the mean heart dose constraints that we had followed for our patients who had received 3 weeks versus 1 week radiation. Now, looking at this table, you might wonder, when the dose constraints are different, how did we actually compare the two arms? Well, they're not actually different because they're not physical doses. They are equivalent doses for two different treatment schedules. So out of the 223 patients that we had accrued for this trial, 187 received the complete treatment, and out of them, 95 were right-sided breast cancer patients, and 92 were left-sided. Out of the 92, 48 received 3 weeks radiation, and 44 received 1 week radiation. And out of each arm, we were able to train one-third of the patients for breath holding technique, which is a kind of cardiac sparing technique. Now, this table over here shows that we were able to meet the dose constraints we weren't able to meet the dose constraints in roughly one-third of the patients who had undergone 3 weeks of radiation, when compared to 50% of the patients who had received 1 week of radiation. Now, one possible reason for us not being able to meet the dose constraints in even a higher percentage of population could be because we weren't able to train more ladies for the breath holding technique. Now, this table over here shows or consolidates my reasoning. Over here, if you can see, out of the one-third of the patient that I had mentioned who had undergone cardiac sparing technique, we weren't able to meet the dose constraints in only 1/5 of the patients, when compared to half of the patients who hadn't received any kind of cardiac sparing training. Now, there was one more variable at play that we thought might have an impact on radiation exposure to heart, that being the kind of surgery that the patients undergo. One is breast conservation surgery, where a good amount of soft tissue is left behind, and the other is radical mastectomy. As you can see over here, the risk of exposure to heart is higher. Although in breast conservation surgery patients, they receive an additional boost to the post-operative bed. So we thought, does it actually have an impact on exposure to heart? Now, this table over here shows that we weren't able to meet the dose constraints in one-third of the patients who had undergone conservation surgery, and half of the patients who were mastectomized. Now, with all this data, there were two important questions that we need to answer over here. Why did we collect all this data in the first place? And the second, what are we going to do with this data? Or how are we going to predict a lifetime risk of mortality due to ischemic heart disease post-radiation? To answer the first question, I'd like you all to look at these two graphs. The first graph, these graphs show the lifetime risk of death due to ischemic heart disease. Now, this graph shows the same thing in UK females when compared to Indian females. Over here, you can see that the risk in UK females is anywhere between 3% to 4%, when compared to Indian females, where the risk is between 9 to 15%, implying that our ladies face 3 times higher risk of mortality due to ischemic heart disease in their lifetime. Now, let me remind you that this is baseline. That is, this is when the ladies are not exposed to radiation. Imagine what would happen post radiation. This very exercise of imagination led us to an even formidable question. How are we going to predict something that is yet in the future's womb? That is, as Ma'am had clearly mentioned, pointed out that cardiac toxicity is not something that is acute. It is an insidious adversary. Its impact unfolds gradually. So, for that, to deal with this misery, we had developed a cardiac model, and this model was used as I would say, telescope through time that would allow us to foresee and predict the heightened lifetime risk of mortality due to ischemic heart disease. in post-radiation women. So what this model includes is that we multiply two factors, one being the baseline risk of developing disease multiplied by extra risk that is added per unit of radiation, now which would be measured as 8.4% per gray of the mean heart dose. All of that data that we had collected was subjected to this particular model, and this was the outcome. I'll break this down. The y-axis shows the predicted lifetime risk of mortality due to ischemic heart disease, and the x-axis represents the different age groups. So in total, this graph represents the distribution of lifetime risk of death due to ischemic heart disease in different age groups. The diamonds with the dotted line represents the risk of death due to ischemic heart disease in UK women who aren't exposed to radiation. The diamonds with the solid line represent the same thing in Indian ladies. The red one indicates the risk of mortality due to ischemic heart disease in women who are exposed to 1 week of radiation. The blue line indicates the risk in women who have been exposed to 3 weeks of radiation. Now, there are three questions that can answer from this graph. What is the baseline risk? The answer to that question is that Indian women face 3 times higher risk of ischemic heart disease if they haven't been exposed to radiation. The second question that we could answer, what happens post-radiation? Post-radiation, as you can see, there is increase in the risk of death due to lifetime risk of death due to ischemic heart disease. Third question that we can ask is there actually a difference between the women who receive 3 weeks radiation versus 1 week radiation? The answer is no. There's no significant difference between the women who have undergone 3 weeks radiation versus 1 week radiation. Now, with this, our journey here comes to an halt, and I'd like to invite Shagun ma'am to dissect the data further for us. Thank you.
So thank you, Irish. And what I'm going to do in the next few minutes is to compare our data with the existing literature. So what we did was compare our demographic profile and the acute toxicity results with a contemporary cohort of patients who were treated with ultra-hypofractionated regimens in randomized trials across the world or within trials which were conducted in the Indian subcontinent. So the first thing we did was compare our data with the UK Fast Forward trial, which is the trial which established a 1-week course of radiation as one of the standards in early stage breast cancer. And when we look at our patient profile is completely different. And that is the reason we need to do replicate trials in our setting. Our median age is much lower. It is a decade and a half lower. We see more advanced stages in terms of the T stage and the N stage. And in terms of biological aggressiveness, we see more of biological aggressive subtype, that is the triple negative subtype. And all these factors do impose a high risk of recurrence for these women. When we look at other baseline factors, we can clearly see that we are the diabetes capital of the world. And despite these women being young, about a fifth would have hypertension and diabetes. And this would pose a lifetime risk of developing ischemic heart disease in the future survivors. The second thing was to look into the treatment variables as to how it was different from the UK Fast Forward study. And because most of our patients are high-risk women, they would receive chemotherapy as well as targeted therapy, and that would have implications on the long-term cardiac morbidity as well. When we talk about the surgical standards, obviously because majority of our women are locally advanced, they would undergo mastectomy. That is half in our setting as compared to the Western world. Now, this imposes some kind of differences in terms of the specifics of radiation planning. In our patient population, because they have undergone mastectomy, what we do is we place a tissue equivalent material over the mastectomized skin, and that is done to increase the dose to the skin and the scar region, because that's the region where we see recurrences. And in case of conserved cases, we more often tend to give an extra dose of radiation to the tumor bed, which is called as the tumor bed boost. Now, both these factors, because we are increasing the dose, we can have implications on the acute toxicity. In our patient population, because majority of them would be node positive, so thereby volumes of radiation that is is nodal radiation, that would be higher. That can also have implications on the acute toxicity. When we talk about the median follow-up, our median follow-up is very short, and that's the reason we don't want to delve into the late toxicity, that is the lymphedema and the fibrosis rates. What we are restricting ourselves is to the acute skin toxicity, because majority of the acute skin toxicity will be seen in the first 5 weeks of radiation. So when we look at the fast forward results, obviously they're severe toxicity. When we talk about severe toxicity, it is grade 3 or more. It is not significantly higher. Even the mild toxicity is not very different between both the arms. And this is what we compared with the SGPGI acute subtoxicity results. And what we see is that the severe grade toxicity, that is grade 3 or more, which requires more of patient and clinician engagement, is not very significantly higher as compared to that of the fast forward results. So this was quite reassuring for us. The second thing that I want to bring out is when you look at the grade 0 toxicity, and this is slightly higher in our patient population, and the reason being the way the grading is done. Erythema is reported as grade 1, and we hardly see erythema in our patients. We see hyperpigmentation, and that is what has been documented more often in our patients and not being reflected in this toxicity scoring. So the second thing we did was to compare the demographics of our patients with the patients which have been treated at other centers. Now, let me remind you, TMC Kolkata and SGPGI, they are a part of the same trial, the HIPOT Adjuvant, whereas PGI Chandigarh simultaneously was doing a trial which was comparing 3-week course of radiation to 2-week course of radiation. And what we see in terms of the demographics is that the demographics are very, very similar across all these centers. And that gives some kind of a reassurance that whenever the results of the trial are available to us, they would be very widely applicable to our patient population. The only difference that we could make out that the incidence of mastectomies, obviously at PGI Chandigarh, were slightly higher as compared to that of the patients who were treated as a part of the HIPOT Adjuvant in either TMC or SGPGI. Now, when we compare the acute toxicity results, and again, HIPOT Adjuvant, let me remind you, TMC Kolkata, SGPGI are part of HIPOT Adjuvant, which is comparing 3 weeks versus 1 week, whereas PGI Chandigarh was comparing 3 weeks versus 2 weeks. And we can see that the dermatitis, that is the skin toxicity rates, are not very different between not only the 3-week and the 1 week, but also the 2 weeks and the 1 week arm. We would not be in a we're not in a position to comment about arm edema and all, because these are subacute late toxicities, which take some time to manifest. One more thing, there's a bit of a nuance in this comparison, because the toxicity scales which were used at PGI Chandigarh were slightly different, but although not very varyingly different to the toxicity scale that we used at our center. Now, the last thing that we wanted to do was to compare the hard doses across participating centers in HIPOT Adjuvant. And here we are doing a comparison between centers which were a part of the HIPOT Adjuvant trial. The reason why we did so, because there can be some technical differences in the way we plan our radiation. And we wanted to see a dosimetry. And what we saw was that in our patients, although whatever constraints were set out by the trial for the 3-week and the 1-week arm, when we look at population-based averages, we were able to meet those constraints, less than 2 gray and 1.4 gray. But when we look at individual patients, these were less often met at our center. That is about a third of the patients in the 3-week arm and in half of the patients in the 1-week arm. And then that made us wonder as to what is the excess lifetime risk, and that's the modeling study we carried out. And we saw that the lifetime risk of mortality due to ischemic heart disease imposed by this kind of doses hovers around 1%. And this, it's not very significantly higher in the 1-week arm as compared to that of 3-week arm. This is what is replicated in this curves, and these are curves from different centers. What we can see is, of course, the baseline risk for our women is higher as compared to the Caucasian population, but nowhere is the 1 week experimental arm doing worse in terms of the predicted ischemic heart disease as compared to that of the 3-week arm. A lot has been spoken about breath hold. So this is a retrospective planning study that we did at our center and published our results, which clearly tells us that, okay, if you use a breath holding technique, you're able to reduce the doses to heart significantly, be it conservation or mastectomized patients. And in the current study, as Iresh already mentioned, that in patients where we had offered breath hold or done breath hold, we were able more often meeting the dosimetric constraints which were set out by the trial. Now, in summary, our study does confirm very low incidence rates of clinically significant acute skin toxicity. It is similar to the Fast Forward UK trial and other participating centers in the trial. It's also similar to a 2-week course of hyperfractionation, which was published by PGI Chandigarh. At our center, we were very we met the dosimetric constraints less often, but let me tell you, no dose to the heart is safe, and nowhere can we see from the trial that a 1-week course of radiation is adding a greater risk as compared to that of 3 weeks. And of course, techniques like DIBH can help mitigate these risk factors. With that, I end my discussion, and I would like to have comments from 2 of our experts. The first one is from Professor Aditya Kapoor. We would like to have his perspective on the cardiotoxicity imposed by the oncological treatments. What are the implications on long-term survivors, whether we need some kind of a specialty clinics like cardio-oncology, etc. And the second comment I would like to have from Professor Shalin Kumar as to what implications does this kind of a trial, which reduces your duration of treatment, has on the health systems of our country. Professor Aditya, please.
Yeah. So thank you, Shagun. Very, very illuminative and very, very inspirational data. So first of all, I think the intuitive sense of ultra hypofractionation makes it has a lot of science behind it, and I find a lot of analogy with lipids. So because nowadays we are saying, initially we used to say LDL of a particular level, now we are saying ultra low LDL. So it's exactly similar to what Dr. Puneeta and the radiotherapy department presented. There's a lot of science to LDL and a lot of science to this also. The important messages for, I think, the cardiology community would be, first of all, that ultra low or hypofractionation has logic because the cells, as Puneeta said, they are chronically reacting cells, the breast cells. Number 2, the DIBH, again, it's a great technique. There are various ways in which these guys are doing it because the heart falls away from the chest wall. So either it is by active breathing control devices or by RPM, as you described, or maybe free breath hold as well. But I think you guys are using RPM, real position management, or what? Yeah. So, and it will reduce the dose. As far as the data is concerned, I think the Derby study, most cardiologists also know that 7% increase for every gray. And if they divide it into tertiles, the higher the gray, obviously more the cardiac risk. So nowadays what we are doing in cardiology, we are trying to monitor these guys. Initially we used to do a plain echo, but now there is a lot of data to say that GLS, global longitudinal strain, should be done, and if a drop of ejection fraction of 10% or a total fall of global 40% or a GLS which falls by 15%. So these guys are one in which you should monitor them better. And lastly, if the patient gets something, there is some data to show that you might benefit them with some cardioprotective therapy, in the sense ACE inhibitors, ARBs, or even statins. So there is data to that as well. So I think it's a great step. And
so just very quickly, it stands to reason that if you are finishing treatment in 1 week instead of 3, in theory, you could add 2 more patients of breast cancer, but that's not the case. That's very simplistic because it's not the case that you have patients lined up in this way and you could do it. Uh, so the point is that if you have spare capacity, if you are able to spare time, what else can you use it for? Uh, Cardiac sparing techniques have a learning curve, and it takes quite a while to do the QA, the quality assurance of these trials, as these techniques. And that's what we can do when we are able to spare time on machines in terms of workload. Clearly, there are benefits to patients. There are reduced burden of treatment and hospital footfall. They have to come much lesser. There are much less financial cost to them. Now, looking at it more holistically, by 2040, breast cancer in the world is predicted to be 3 million, it's 30 lakhs per annum. And 70% of predicted, and 70%, of the predicted 1 million deaths will happen in low middle income countries where you have hardly, in many of them, you have very few linear accelerators. India is probably one of the better ones. We need 1,400 accelerators for 140 million. We have about 750 or 800. So now with poor treatment infrastructure, that's all the more reason that you should be more process efficient. And there is a case for hypofractionation, and we try to do that in as many sites as we can. It also limits financial toxicity, the time of coming here, staying here, the cost to treatment, and greater compliance greater compliance of people. They're more likely to spend 2-3 weeks. Women, particularly, have household reasons. They have household commitments, and long treatments are really a deterrent. So there is another thing that from the surgeon's perspective, and the surgeons will recollect that we had this trial that if you give, when you do a sentinel node biopsy, and if the sentinel node biopsy is positive, then 2/3 of the axilla will harbor tumors and 1/3 will not.
We need to wrap up because we have very little time left for discussion.
Right, lovely. So, fine. Nodal radiotherapy to the axilla is safe, and it is a safer alternative than dissection. And if you give radiotherapy to the axilla, there is half the amount of lymphedema. And this 1-week radiotherapy has been proven to be as good as the 5-week therapy, which was done in the Sarah paper. So in summary, a few acknowledgements are in order. This is not possible without endocrine surgery. Their great support over the years, 3 decades literally. Pathology provides critical inputs for our diagnosis, for our further management. Radiology helps us. Cardiology, we have already heard, and we have nuclear medicine. We must acknowledge our collaborators. The UK team came into India and handheld us. The main driving force here was TMC Kolkata, which started it, and we had collaborations with CMC Vellore. We've had funding from NARC Foundation and Lady Tata Memorial Hospital Trust. And of course, we have to thank our breast cancer patients for teaching us how to do it better. Thank you very much.